The next half an hour, I'll try to discuss, like in a few points, and then initially with some little bit of an introduction about Asha Academy of Mood Disorders, about which Asha Bipolar Clinic is a unit of Asha Academy of Mood Disorders. And as I told you that I am the director and I run that. This is the vision: reinventing recovery, reality, and mood disorders. Doesn't it sound a little bit odd? It's almost 100 years back. Kraepelin has classified psychosis into good prognosis, mood disorders, and then not good prognosis, thought disorders, and then dementia precox. And then today, after 100 years, and then somebody is saying that I'm reinventing, but that's unfortunate thing. What I see is that very, very unfortunate thing. Mood disorders, which are even now, I believe that is a good prognosis disorders. Of course, there are recurrences, but in the short term, there's a recovery from the episode. This is what of late has been chronic, disabling, lot of disability, and then functional deterioration. What not? The whole lot of things coming. So I feel that we need to do something about it. Reinventing recovery reality, and the mission is how do I evolve therapeutic concepts to achieve this? This is what is going to be the thing. This is what I've been trying to do in the last few years within my bipolar clinic. Next two slides. I made a statement then that they're good prognosis. I'll present some of the data. These are three long-term studies. One is NIMH study, collaborative depression study in 2002, where 291 patients. These are all very long term, about 25 years, 27 years, 25 years, and then about a reasonably good number of patients, 290, again here 219. NIMH study, Jules Angst, all of you know that Pitamaha in bipolar disorder. Solomon is one of the research workers in this. And this is important point here. If you look at about 50% first episode is below the age of 21. I'm going to come back to this point again and again in the next few minutes. This 20-25-year-old follow-up studies, what are the findings? 25% of subjects remission within about 5 weeks. Remission recovery, I put in the same thing because now I don't think we discuss about it. We can call remission and recovery the same now after CanMat 2018. 50% of subjects within 13 weeks. 50% of the patients with bipolar disorder, whatever may be the episode, they recover within 3 months. What more we want? What do you want? Like, why can't we say that this is a good prognosis? From the episode is curable. That's what I keep talking about. Even if you take it, about 8-9 months, 75% of patients. I think clinical setup, we do see much more recovery than even 75%. I keep asking every time whenever I do a meeting then that what is the percentage of chronic mania in our clinic? People say that less than 5%, doctor. I think more than that. So more than 5% in about 8-9 months they recover. 3 to 4 episodes in 10 years. I'll do, it may not be the correct thing to do, but I'll do a rough calculation here. Suppose we say that in about 9 months, 10 months time, episode recovers. There are about 4 episodes in 10 years. 10 into 4, 40 months. It's about 3.5-4 years. The rest of the 6 years, this man is euthymic. This man is asymptomatic. There is symptomatic recovery. What do we want? Why can't we call this as a good prognosis disorder? That's what I showed this slide to show the symptomatic recovery. Then this slide, this is about 2017 study. You see that this at least 4 years follow. What are the parameters? We all see the global assessment of function, employment, and self-assessment. These 3 parameters, when they assess the patients, average period it takes about 6.5 years follow-up in bipolar disorders. This is the result. Do not support the hypothesis that functional outcome deteriorates over the course. The previous slide I showed that symptomatic recovery. Here I am saying that functional deterioration is not there, which means that there is functional recovery. I personally believe that most of the time, if there is a good symptomatic recovery, HAM-D less than 7, maybe YMR is less than 8, patient goes back to a functional recovery. These 2 slides show that this is what it is like in a bipolar disorder. Now, this is in the background of good prognosis. Over the last few years, I am almost under the impression, and I am almost believing this more and more and more, that there are 2 important things in mood disorders. There's a gross under treatment of major depressive disorder. and severe overdiagnosis and then over-treatment of bipolar disorder. Under-treatment of major depressive disorder, over-diagnosis and over-treatment of bipolar disorder, which has become sort of, I feel, it's my personal feeling, it's rampant. Under-treatment, it's an opportunity cost. This is a business term. You're losing an opportunity to treat MDD, which is costly. And the recent NIMH, our NIMAN survey showed that 2016, 2.5% current prevalence in India. As on today, there are 30 million persons with depressive disorder, and the gap is 85. Actually, I think it's 89. I put it as 85. We don't treat them properly. Whatever may be the reason, there may be 100 reasons, but this is what I feel is under treatment. And second thing is, at the same time, over-diagnosis and over-treatment of bipolar disorder. Over-diagnosis and over-treatment, we have on one side opportunity cost, and second thing is that you're giving them all the drugs and the drug-induced adverse events. These are the two major costs of this because of this kind of a problem, what we are seeing. Under-diagnosis of this, over-diagnosis of BD. These are the two major, I think, problems in the management of mood disorders. At least that's what I feel that. This particular point, how important it is, maybe later I'll come to in some other sessions. Now, look at this. BD1, bipolar disorder 1, lifetime prevalence, WHO study is 0.6%. If we include all the BD2, subsyndromal spectrum and all things, 300% increase in the prevalence. Pure cases are 0.6%. These are in the fringe, and then other specified, unspecified spectrums are 300% increase. It cannot be. Like, right, we may be missing something, but it cannot be so much. This is what the problem is. And then this is one point, I think you're all psychiatrists, we all know that. Problem is age of onset is 25 years. If you look at this figure, 40% of the patients with the bipolar disorder or even maybe MDD starts below the age of 20 years. Now, pause for a moment. A patient with MDD or whatever the underlying problem, you diagnose as a bipolar disorder. Patient is in his teens, adolescent, 17, 18-year-old boy who comes with some depressive symptoms and irritability. You make a diagnosis of bipolar disorder, which is actually not correct. And the moment you make a diagnosis of bipolar disorder, you know what is the first thing you do? Start the mood stabilizer, so-called mood stabilization. If not on the first episode, it's the second episode. That is exactly the problem. See, actually, it's not the diagnosis itself problem. It's a therapeutics which is going to be the problem. So at the age of 18, 19, for that youngster who is with some personality or like in minor depressive episodes, you make a diagnosis of bipolar disorder, and then you put him on so-called mood stabilizers. Doctor, how long, doctor? In India, life expectancy is now 27 years. 67. So from 20 years, next to 50 years, you're going to be on this mood. I don't know. Side effects profile. They're not like in the other really therapeutically so much useful. This is always bothers. Wrong diagnosis at the age of 20 and putting the patient on long-term treatments for years and years together with valproates, oxcarbazepines, lithiums, and all those things. This is where a problem I see, that a huge problem in this concept. I see that diagnosis incorrect, inappropriate acute care, and obviously this is what it is. Now, this is the background before I start onto bipolar 2 disorder. This is what good prognosis, which I've shown, symptomatic recovery, functional recovery is there, under treatment of MDD, and then over diagnosis and over treatment at the age of very early age, which is a big problem. Now, this slide, I think some of you who are in Hyderabad may be very, very familiar. I keep showing it. This is not just to show that, okay, right, I've done. But as I told you, that this concept has been brewing in my mind for quite a few years. 2014, that is the first year World Bipolar Day we celebrated in Hyderabad. And then, right, on 30th March, I was one of the speakers. And then that time, Asha Bipolar Clinic request or demand is one of my slides. 6 years back. Replace mood stabilizer with prophylaxis. All along, I've been telling this is not a correct term. Fortunately, CanMed 2018 has done away with the term mood stabilizer. Second, Bari Bipolar 2. This is what I asked 6 years back. And now I'm happy that this is slowly or the dream of mind, the concept of mind is becoming a more and more of a reality. This is the culprit here. Irritability as a criterion for bipolar disorder in DSM-5. This is the criterion. If you remove that criterion, irritability, and say only grandiosity, 50% of the overdiagnosis comes down. This is what my definitely the feeling, especially in childhood bipolar disorder. Making like a diagnosis based on irritability is doing lot of harm. But this is what I just want to share this, because like for the last 5-6 years this has been happening. Now, sir, here let me sort of I've been talking about certain things like a diagnosis which has been there for a quarter century. I am now coming and saying that no, it doesn't exist. There's nothing like that. So it doesn't mean that I am talking something against evidence-based medicine. I completely believe and I see that evidence-based medicine is science we all have to follow, but this can happen. Same evidence-based medicine, the purity may not be there exactly in everything. The same evidence-based medicine has given me escitalopram, an excellent drug, absolutely excellent antidepressant. The same evidence-based medicine has given me reboxetine also. Just because it is reboxetine, we can't completely say that, okay, evidence-based medicine is not like, and that, no, it's not right. So there may be some, we need to now sort of separate out how much of purity it is, but as a concept while this is where I think the future is this only. We cannot just say that no, evidence-based medicine, it's not like it's all manipulated and all things. Please don't think like that. I don't want anybody to think like that. So discarding this is discarding more than discarding the baby with bathwater. DSM-5, as I told that bipolar 2, now I'm saying that it's a myth, but it's in DSM-5. But I have a great respect for DSM-5. It has done so much of a diagnostic criteria, and then so many things it has brought in, which streamline the diagnostic components. But there are some deficiencies which I feel that somebody else may not feel that, but still deserves great respect. I don't know much about ICD, but DSM-5 or DSM-4 I generally follow that, and I have a lot of respect for that. Evidence-based medicine, we clinicians listen to you with respect, my dear evidence-based medicine, but what we want is trustable evidence, trusted evidence. This is the term I took from the Cochrane review, trusted evidence. When they talk about trusted evidence, that means that there is some other evidence which is not so much trustable. That's the only thing. Just because there is some evidence which is not so much trustable, let's not throw out everything. No. And I do not attribute any kind of negative or kind of motivations to anything. That's why I just put this paragraph here very clearly. I want all of you to read that, because in the next few minutes, I'll be making some comments on the diagnosis and then some of the therapeutics also. In the next few sessions also, I'll be making. Actually, this is, it's written as a case series, but today I'm not going to talk about the case series. I'm going to talk about only bipolar 2. The plan is the next few weeks, I plan to present some of the bipolar disorder cases which have been collected over a period of 10-15 years. And then every week, maybe 2-3 cases, I thought I'll present that. See, read this. This one, I think you all have to read. No. These are the people, tremendous amount of time and effort. They deserve praise. This does not involve a deliberate attempt. This may be failures of the peer review process. It's not a purposefully done, maybe one odd event maybe happened that, but let's not look into that. So evidence-based medicine is science, but only thing is I have a request. We are listening to you, evidence-based medicine. Now I think time has come that you listen to clinicians' experience. Clinicians' experience is very, very valid. The volumes and tons of experience and then wisdom they have. I think there has to be, it's not always from here to clinicians, but from here to EBM also should go. You must listen to clinicians for guidance. This is what I want. This is one of the main reasons why I put this slide, but definitely evidence-based medicine we all have to respect.